Hello everyone, hope you're all doing good. This is Dr. Agalya, your organic faculty, and in this video we are going to continue with cervical intraepithelial neoplasia discussion. So here we are going to learn how to prevent HPV infection, which is going to be the etiology for cervical intraepithelial neoplasia, which is the precursor lesion of cancer cervix. So indirectly we are going to see how to prevent cancer cervix as well as how we are going to manage cervical intraepithelial neoplasia, right? So let's start. Now, in this video, I am going to discuss with you about all the guidelines that has been given by WHO. Okay, so we will be discussing so much of the algorithms that are given in the guidelines. Okay, so WHO suggests using any of the following strategies for cancer prevention for general population in women. Okay, so here we divide women into two categories. One is general population and another one is people who are having HIV. Okay? Yes. Now for the general population, we can do HPV DNA detection in a screen and treat approach, as we have seen in the previous video, and this will be started at the age of 30 years with regular screening that will be done once in 5 to 10 years. Okay? The same way, we can also offer them HPV DNA, HPV DNA in a screen, triage and treat approach starting at the age of 30 years again, and this will be continued with regular screening every 5 to 10 years. So the point here is, when the woman is not a HIV woman, you have to screen her with HPV DNA screening, and she will be taken either via the screen and treat approach or the screen, triage and treat approach, right, starting from the age of 30 years and screened every 5 to 10 years. Is that clear? Right. Now next one is, for people who are living with HIV, WHO suggests the following interventions. Okay. So it will be, you have to do HPV DNA detection, and it will be only screen, triage and treat approach, and you have to start screening them much earlier, right? Like it will be started at the age of 25 years itself, and regular screening will be done every 3 to 5 years. Clear? Right. Now, I am going to discuss with you one of the important preventive strategy for HPV infection, that is HPV vaccines. Okay. So, let's discuss about the vaccine and how it can prevent and what it can prevent. Okay. So, we will discuss the vaccine and it gives protection against what? Okay. Yes. First one is Cervarix. Okay. Cervarix is effective against HPV 16 and 18, and it protects against CA cervix. Okay. And the next one is Gardasil. So this is effective against HPV 6, 11, 16 and 18, and it is effective against, since the benign serotypes of HPV are also included, this can give protection against, yes, genital warts also, and it can also prevent cancer cervix. Now, there is a new vaccine that is available, that is Gardasil 9, which will be covering most of the serotypes of HPV like 6, 11, 16, 18 and almost all serotypes which causes cancer cervix. This is very important for you. Those include 31, 33, 45, 52 and 58. All these numbers also important. Okay. So, here also we will get protection from genital warts as well as from the cancer cervix. Is that clear? Yes. Now, let us see how these vaccines are prepared. So, these vaccines are prepared from L1 capsid protein. L1 capsid protein from virus-like colonies. Okay. And there is lack of DNA in them. Okay. They lack DNA. So, they will become non-infectious, but they can bring about a antibody response when given. Okay, that's it. So, how it will become highly immunogenic? It becomes highly immunogenic by stimulating production of specific humoral antibodies, leading to the prevention of entry of HPV itself into the epithelial cells. Is that clear? Right. Now, when will you take this vaccination? So, ideal time to take vaccination is before the onset of sexual activity. Okay. However, prior sexual activity or HPV related disease or even a positive HPV doesn't stop you from taking this vaccine. Okay, so there is no absolute contraindication to take this vaccine. Okay. So, however, prior sexual activity, HPV related disease or even a positive HPV test are not contraindications for taking this vaccine. Clear? Right. Suppose if due to any reason, like if there is pregnancy in the female and the vaccine schedule is interrupted, means there is no need to restart it again also. Okay, just it will be continued like the previous schedule. Okay, right. And remember the points. Vaccine is a live vaccine, so it is contraindicated in pregnancy. Then it is, however, safe during lactation, and it should not be given to patients who have allergy to yeast or who have recent febrile illness. Okay. Now, let us see the age group. Age group for giving this vaccine will be between 9 to 26 years. So, ideal age is actually 8 to 12 years, but you can cover people at least from 9 years and extend it up to 26 years also. Okay? Yes. Now, FDA recommends the usage of this vaccine even after 26, that is 27 to 45 years also. Okay. So, this is the ideal recommendation of the vaccine. However, WHO recommends covering the vaccine at least up to 26 years, whereas FDA recommends this vaccine to be taken up to 45 years. Clear? Right. Now, let us see the dose schedule. So, more than 50 years means we will give 3 doses. Okay. So, first, second and third dose, like between first and second dose there will be some 1 to 2 month gap, and then between first and third dose there will be 1 to 6 months gap. Sorry, it will be 6 months gap. Okay. Yes. Now, suppose if the female is less than 15 years means, less than 15 years means, you can give 2 doses, that is first dose and second dose, which will have 6 to 12 months gap. Clear? So, this is for your more than 15 years and this is for your less than 15 years. Clear? Yes. Now, there is a new recommendation that came out in 2022 April by WHO, that was a WHO SAGE recommendation for giving this vaccine. Okay. So, it recommends giving the children between 9 to 14 years should be given 1 to 2 doses of the vaccine, and those between 15 to 20 years are to be given 1 to 2 doses again. Then more than 21 years have to be given 2 doses, okay, and that will be given at a gap of 6 months. And finally, if they are HIV positive female, they should be given 3 doses, okay. And there is also a target that is set by WHO to be achieved by 2030, okay. So, this is called as 90-70-90 strategy, okay, 90-70-90 strategy, right. So, what does 90? 90 means, first 90 says that, so first 90 says that 90% of the eligible girls are vaccinated against HPV. 70 means 70% of the eligible women will be screened at least twice in their lifetimes, okay. So, this is for screening, okay. And next one is treating, okay. So, treating 90% of them who have a positive test or who have a screening test positive, okay. So, that will include the palliative care also. So, it is 90-70-90, which is VST, vaccine, screen, treat. You have to vaccinate 90% of the eligible girls, then you have to screen twice the eligible women, and then you have to treat the people who are getting a positive test or who has a lesion. Clear? Right. Now, we are going to discuss about the management of cervical intraepithelial neoplasia. So, these are the things I have taken directly from the guidelines. Now, we are going to discuss about the primary cytology, screening and colposcopy drainage. Now, this is for both general population as well as HIV positive women. Okay, so what will we do is, we will do a cytology first, that can be a conventional or liquid based cytology. Cytology is nothing but your pap smear, right? Then if in the pap smear it becomes negative means you will screen her only after 3 years with cytology, okay. And suppose in the pap smear if it becomes ascus means you have to screen her with immediate triage with HPV test, okay. If HPV test is positive, then you offer her directly colposcopy. Suppose if HPV test is negative, you can rescreen her in 3 years again with cytology only, and if it is negative, again you will screen her every 3 years, and if it is becomes more than ascus state means you will take her for colposcopy, and whenever she is more than ascus, you will take her directly for colposcopy. Is that clear? Right. And with colposcopy, the treatment plan will be based upon the histopathological diagnosis, whatever it comes, right? Yes. And the next one is HPV DNA screening and HPV 16/18 triage, that is screen, triage and treat approach. So, this is also for both general population as well as women who are living with HIV. So, what we are going to do is, we are going to offer her HPV DNA testing, okay. HPV DNA testing will be offered either by self-sample or it will be collected by the clinicians, and if it is negative, you will be screening her with HPV test in every 5 to 10 years for the general population, but if she is a HIV positive woman, you will screen her once in every 3 to 5 years. So, when HPV DNA testing is positive, then you have to see her whether HPV 16 or 18 is positive. That means they are high risk serotypes. When they are positive, then you have to determine her treatment for ablative treatment. That is, you have to treat by ablation after testing her with VIA, that is visual inspection with acetic acid. You will be using 3 to 5% acetic acid, And if they are eligible for ablation, you can offer her LETs or thermal ablation. And if she is not eligible for ablation, then you will go for LEEPs. Okay. Then if the positive for LEEPs, in LEEPs the histology is positive, and if it comes to be less than CIN3 or adenocarcinoma in situ, you will follow up her after 1 year. Okay. And if you offer her ablative treatment also, you will follow up her after 1 year. But if there is the cancer, means what you will do, you will evaluate further and a biopsy will be taken again and she will be treated according to her carcinoma stage. Clear? Suppose if HPV DNA is positive right at the beginning itself, okay, any other high risk HPV serotypes are positive, then she will be taken for via triage once again, then follow up steps according to the algorithm 5 will be followed. Okay. So that is how it will be done. Okay. Now let's see algorithm 5. So this is the via triage. Okay. Here we are going to do HPV DNA screening and via triage. So this will be done for both general population as well as people with HIV. So when you get HPV DNA testing done and it becomes negative, you will be rescreening general population at 5 to 10 years, and women with HIV will be screened every 3 to 5 years. This is done. So you are screening her. The screening becomes positive, that is HPV DNA becomes positive. Then you will screen her with via triage, and if via triage is negative, means you will repeat the test after 2 years, that is HPV test after 2 years for general population and within 1 year for HIV women. Now this is new here, right? Yes. Then if the via triage is positive, then you have to check her whether she is eligible for ablation. If she is eligible for ablation, give her ablative treatment and follow her after 1 year. And if she is not eligible for ablation, offer her LETs, then check the histology. If it is coming less than CIN3 or AS, then you will treat her after follow-up, treat her after 1 year. Then if it is coming as a cancer, then she will be directly taken for the cancer management, just like how we see in the algorithm 4. Clear? Right. Now coming to algorithm 6, which is about primary HPV DNA screening and colposcopy triage. Okay. So when HPV DNA screening is done, you have see whether it is negative. Negative means what you will do, screen her with HPV in 5 to 10 years, and if she is a woman living with HIV, means she will be screened in next 3 to 5 years itself. Then if it is positive, directly offer her colposcopy and further management based upon the colposcopy and the histopathological examination. Clear? Right. Now next one is primary HPV screening and cytology triage followed by colposcopy. This is also one kind of screen, triage and treat approach. Okay. So here HPV DNA testing is negative, then yes, without HIV 5 to 10 years and with HIV 3 to 5 years, this is done. And HPV DNA is positive, you will go for cytology triage. If cytology screening is negative, then repeat test after 2 years for women without HIV, and for women with HIV you will repeat it after 1 year itself. Yes, and if it becomes negative, then you can follow up like 3 to 5 years, 3 to 5 years and 5 to 3 years and 3 to 5 years. And if it becomes positive, then colposcopy has to be done, and further management will be depending upon the colposcopy and histopathological diagnosis. Suppose the cytology itself shows there is ascus or even more worse lesions, then it will be taken directly for colposcopy. Okay. So follow up at 12 months post treatment for the general population of women. Okay, how you will follow up after 12 months. So if treated with ablation or LEEPs without histopathology results are available, if treated based on histopathology of CIN2 or 3 or adenocarcinoma in situ, then follow-up test will be done at 12 months, and if it is negative, back to routine screen interval depending upon the primary screening test will be done. That means her routine screening. How? That is her routine screening, that is will be done every 5 to 10 years. Then if it is positive, means she will be retreated with LEEPs again, and post treatment follow up will be done after 12 months. If there is suspected cancer, then referral for evaluation biopsy and further management will be done, right? Yes. Now this is for women who is living with HIV. Okay, so she will also be treated with ablation or LEEPs, or if treated based on histopathology for CIN2 or 3 or AS, then you will be following her up after 12 months. If it is negative, she will be repeated after 1 year again. Then if it is also negative, then her routine screening will come, that is once in every 3 to 5 years, right? And suppose if it is positive, she will be retreated with LEEPs, and post treatment follow up will be done again in a year. then suspected cancer is there, then depending upon the biopsy, the management plan will differ. I want to speak something here about colposcopy, because every time I am telling colposcopy is the final test we are offering, and after that the treatment depends upon the colposcopy findings. So basically we have 5 colposcopy findings based upon which a score called sweet score is given. Okay, it is sweet score, and based upon this score only we will be classifying the lesions accordingly. So the 5 lesions which we will look in the colposcopy will include acetouptake, then you have to look the margins and surface, look for the vessels, lesion size, iodine staining, and each parameter will have 0, 1 and 2 scores depending upon the abnormality and severity. Okay, and the score finally will be ranging anywhere between 0 to 10. Okay, so if the score is between 0 to 4 means then it is interpreted as CIN1. Score 5 to 6 is interpreted as a high grade lesion, or it is a CIN2, and then score 7 to 10 is now recorded as invasive cancer. Okay, invasive cancer, or it is CIN3. Okay, suspected invasive cancer. Okay, it is not invasive cancer itself, it is suspected invasive cancer, or CIN2 plus or CIN3. Okay, yes, right. And the next one I want to tell you is about the ablative treatment. I was telling every time ablative treatment will be given. So what are the ablative treatment we will have? Yes, we already know it is cryoablation and thermal ablation. Okay, suppose leads which can be offered after ablative treatment is not available, then you can offer her CKC also. CKC is nothing but cold knife conization. Okay, then leads and LEEP usually indicate the same procedure. There shouldn't be any confusion. Okay, now if the histology is not available, then what you will do? You will ask the woman to come after 1 year, and if there are any signs of CSAV, she has to report earlier. Okay. Now, when is hysterectomy done? Okay, so indications of hysterectomy in CIN: when she is a Paris, elderly woman, or there is any associated uterine pathology like fibroid, dysfunctional uterine bleeding, when there is micro-invasive carcinoma, or there are margins of conization which are not free of CIN. Okay, the margins are not free of CIN, and when you think the patient will be non-compliant for follow-up. Okay, so all these things will be indications for hysterectomy in a CIN positive patients. Clear? With this, we'll be completing the topic on CIN. Until we meet in the next video, keep going, happy learning, take care and bye-bye.